start the recording, Stephen. Welcome everyone to this meeting of the Highland Health and Social Care Committee. Welcome and apologies. Stephen, do we have any apologies?
Apologies from Philip McRae and Joe McBain.
Thank you very much. I don't think we've got any new members. Just to let you know, we were unsuccessful with our recruitment for our lay outstanding. We've got 2 vacant posts from lay members. So we're in the process of going out to advert again. So hopefully we'll have some progress on that by the time of the next committee meeting. And apologies, Stephen, just to say, Di emailed me just to say she wouldn't be in attendance today. So if we could note her apologies for the meeting as well, that would be very helpful. I'll move on to 1.2, declarations of interest from anyone for any items on the agenda. Nope, I am seeing no hands, so I will take that as no declarations of interest. Item 1.3 on the agenda, the assurance report from the 8th of May, associated action plan and work plan. I'll maybe just take them all as one combined document. We've got the minutes there, a PDF document and an Excel spreadsheet. And I think Stephen managed to get the correct work plan and actions round everyone. We had a merger of a couple of documents there. So we'll take the assurance report first of all. Any matters of accuracy anyone would like to pick up on that? Nope, I'm not seeing any hands, so we will accept that as a true record of our meeting on the 8th of May. Anything anybody wants to pick up in the action plan or the work plan in terms of an update? I think the work plan really there is just to note the dates of our meetings and our intended topics. I would actually just say that if we could note on that we've got a strategy session, I think, Stephen, on the 24th, their development session on that. So if everybody could just make sure that's in the diaries. But again, I'm not seeing any hands, so we will move on from those. And any matters arising from any of those items, folks, which we're not going to cover later on in the agenda at any point? Nope, again, excellent. We're not going to see any items there. Lovely. So we're going to move on to, just to let everyone know, I'm going to sort of merge item 2 and item 3.1 almost into one item, but maybe with a couple of pause points in there. I'm going to just to give everybody a little bit of prep time. I've spoken to Pam about this. So first of all, I'm going to ask Elaine to take us through the year-end 23-24 finance report. Not a lot of depth in that, because it's not really moved from the provisional one that we saw there. But I think they were just to understand where we are now that Elaine and team have we've now got the accounts all signed off and submitted to Scottish Government. We can actually report on the final figures there, just to get an understanding there. But I think probably just to understand the movements which we had at the year end. I'm then going to ask Elaine to take us through the NHS Highland wide financial position for 24-25, because again we've now submitted our financial plan to Scottish Government as part of our annual delivery plan, and that has now been through the board, and we can now bring the committee up to date on where we are in that. We'll then maybe switch tack slightly, and Rhiannon will take us through the NHS Highland-wide approach to transformation for 24 and 25 and beyond. She'll take us through her presentation, but we've all had it in plenty of time. So I've asked Rhiannon maybe just to take us very quickly through the slides, and actually, because what I want to do is actually to leave maximum time for discussion and comment from members. Pam will then come in and talk about Highland Health and Social Care specifics as it relates to the transformation plan and where we're going, what our intentions are, what our hopes are, and what our targets are. And then we'll close down that discussion by just Elaine will take us through the month 2 financial position for the board and the Highland and Health and Social Care partnership. And we always caveat month 2 where it is very early in the year, but I think we can already see some messages in there which we need to be mindful of. And what I'm really trying to get out of all of this is that we have absolute clarity across the committee in terms of the challenges we actually face in 24-25, both for the board and then for us as a committee, and maybe to have a think about, and this might feed into our development session, what our role as a committee might be in terms of going forward to actually provide that assurance to the board, but also actually to support Pam and her team in terms of how we can actually help deliver the challenge ahead to us. Okay, so with that, I shall pause and I'll maybe hand over to Elaine to take us briefly through the 23-24 year-end position. Now, I think, Stephen, if I'm correct, there was a paper come out this morning, but I don't know if Elaine's going to put anything up on the screen or anything like that. That's how unrehearsed we are. But okay, over to you, Elaine.
Could you just bear with me for a second? I'm having some Teams issues and I've got a workaround, but it's not as quick as normal. Hopefully that's sharing now, and I'm just trying to get everybody back on screen. Okay. So yeah, as Jenny mentioned, we presented a draft position, but that was still subject to audit. So audit's now concluded and the signed off accounts have been submitted to Scottish Government. And once they're laid before Parliament, they'll be in the public domain. Fortunately, the position didn't actually move through audit, so a good place to be in, that there was no adjustments required. But I'll just quickly take you through where we are. So the graph here on the first chart, we've got the red blocks, which were the plan deficit. So that was the plan that we submitted to Scottish Government in March 2023. And we'd initially expected to have a gap of 68.7 million. During Q1, Scottish Government announced significant additional funding, and the request there was that was taken to support the overall financial position. It wasn't to be used for any investment within board. So the green block is that revised position where we were expecting a deficit of around 56 million. Where we actually, excuse me, we delivered a position of an underspend, excuse me, sorry. Apologies, I've got an irritating cough. We received brokerage from Scottish Government of 29.5 million, which allowed us to deliver an underspend of approximately 300,000 at the end of the year. This moment in time, we don't know whether that will be returned in 24-25, but in previous years, when we've been supported by brokerage, it has been. So I've just here taken that reconciliation from the initial plan that's submitted to Scottish Government to how we got to that year-end position. So within the initial plan that went to Government, we had a 98 million gap. Then setting aside that, we had a 29.5 million target for cost reductions and cost improvements. What we actually delivered in year in respect to reductions and improvements was just over 13.5 million. We then received a number of blocks of additional funding throughout the year. As we got the sustainability funding that came in June, just over 8 million. We received support from Scottish Government for the adult social care element of the pay award. So just as a reminder, although Scottish Government fully fund the pay awards, that's for the pay awards for the posts that sit within our baseline. So adult social care sits out with NHS Highlands baseline funding. So Scottish Government aren't obligated to fund that, but they have done for the last couple of years. So it's a risk that we see year on year, but they provided additional funding in June 2023. We also get additional allocations from New Medicines Fund, just at 6.6 million. We get a supplementary allocation for pay of over 6 million. The year-end surplus for 2022-2023 was returned, so just under 400,000. And then in March, as we approached year-end, there was a significant allocation in respect of health consequentials that came from UK Government, and we also received some sustainability funding as well. So that's almost 10 million, which takes us to a position where we're just shy of 35 million of additional funding that we hadn't necessarily been anticipating at the start of the year. We also saw a reduction in top slices for national costs, and there was an element of financial flexibility built in there as well. So that's balance sheet adjustments where we didn't utilise all the funding or the resource that we had sitting in the balance sheet, and we released some of that to the overall financial position. Taking into account some short-term cost reductions and slippage in allocations of 18 million, and then that brokerage value of 29.5 million, we've come to the year-end surplus of 265,000. How that was split across the operational areas: within the Health and Social Care Partnership, an overspend of 10.6, within acute, an overspend of 22.3, and within support services, we're seeing an underspend there of just over 31 million, and that reflects the brokerage that came in from Scottish Government at the end of the year. Argyll and Bute delivered a break-even position, with them using the flexibility that they have to take any underspend to reserve. So the overall funds in position, 1.2 billion, and that is including the brokerage of 29.5 million. So we did see a significant level of allocations that were received through towards the latter part of 2023, 2024, and it had a beneficial impact on the financial position, but it does create a bit of uncertainty as we progress through the year. Looking at the partnership position in a bit more detail, North Highland Community, an overspend of 8.9, within mental health 6.3, and within primary care almost 2 million of overspends. All of these positions are being driven by use of supplementary staffing, both for agency nursing and medical locums. And within primary care, there was also an element of overspend there for drugs costs, and that's really a reflection of an increase in volume and an increase in price. So the split across health and social care, when we take into account the property cost for social care, there was a slight underspend, 188,000. And within health, the overspend was 10.8 million. So a significantly better place within social care. And that reflects allocations that we received in 2022-2023 that we had anticipated would be non-recurring, but they came through on a recurring basis and allowed us to improve the overall position there. This slide's showing the summary breakdown across the different service categories, and also showing the spend that we've had on agency nursing within our in-house care homes. So 1.7 million spend for the full year on agency nurses. So as I mentioned, balanced position was delivered within adult social care. The main element was due to that recurring allocation that we received. We also paid additional payments to providers, and they were coming in at about 500,000 less than we had been anticipating. And at the moment, whilst we've set the position for 2024-2025, we are working with the Highland Council on agreeing a quantum at an early stage, because we are expecting that will improve the position for 2024-2025, but we've just got to work through the allocations and get that confirmed with Highland Council. I'll just skip through these next slides, but they're there for everybody to have a look at. They're just summarising other positions. So looking at the cost improvement programme, 29.5 million. At the end of the year, we were reporting slippage against that of almost 16 million, which gives us a delivery against the programme of about 13.5 million. And you can see just the slippage there on that table at the bottom. These were the schemes that we had underway in 2023-2024. I won't go into them in any great detail, but it just shows how they progressed throughout the year. Just pulling this out for just of interest, the supplementary staffing position. So we had a number of schemes in the cost improvement programme for 2023-2024 that was relating to reducing supplementary staffing, so both agency nursing and medical locums. But as you can see, the spend in 2023-24 was actually about 7.8 million higher than 2022-2023, so it's still an ongoing issue. And as we go into 2024-2025, we're looking at trying to bring those costs down with a number of programmes of work ongoing. So that spend on supplementary staffing of almost 69 million in the year is set aside an overspend within pay of 5.3 million. So it's shown just the impact that it's having on the overall financial position, the reliance that we do have on agency and locum staffing. The spend pattern through the year was fairly static. We had a slight increase in month 7, but there was no significant movements throughout the year. This is just presenting it in a slightly different format where we've got the month-on-month position across the different operational areas. And here we can just see the total spend across the 12-month period. The subjective analysis is just pulling together all the different categories of spend. So you can see that we're seeing spends against all areas within the reporting that we do at the moment. So we know that drugs is a significant issue, so a number of schemes ongoing both locally and nationally to try and reduce drug costs, work ongoing around new medicines funding as well. Main area of overspends when you look at the subjective basis is within the social care independent sector cost, so that's playing through the overall adult social care position. Capital, just as a quick summary, we had capital allocation of 26.7 million, and that was fully spent at the end of the financial year. So there was a piece of work ongoing with Scottish Government following the announcement of the pause in the larger capital projects, which saw us rebalancing some of the projects. So we pulled forward some spend that might have went into 2024, 2025. Into 23-24, just to allow us to come out a suitable break within the schemes, both within Lochaber and Caithness. So I'll stop sharing that one. I don't know, do you want to take questions on that just now, Jerry?
Yeah, I think that would be good, Elaine. We'll maybe just take a couple of minutes and just so we're all understanding where we are at the end of the year we've just closed down. Any questions of detail that anyone would like to pick up with Elaine? I'm not seeing any hands, so I think you're getting all. Oh, there we go, Anne.
I'm not sure if Elaine will be able to answer this or not, Jerry, but so I'm conscious that we have a paper later on in our agenda around learning disability services. That was clearly a significant area of overspend, Elaine, in terms of the year gone by. So I wonder, I'm afraid that I haven't been able to read the detail of the month 2 position, which just came out to us. So I was wondering if that trend is continuing. Is it getting better? Is it getting worse? And I was wondering if we could have a little bit more detail, if possible, about the breakdown of that overspend in terms of is it supplementary staffing in New Craigs? Is it in the community? Is it, largely out of area placements? Just to give ourselves a bit of context for the discussion later in the meeting. Thank you.
And come back just on the 2024-25 position we were looking at the moment. So at the moment, it does look as if that trend within LD is continuing. We're forecasting an overspend of just shy of 2 million at the end of the financial year within that area. We know that there are a number of high cost packages that are contributing there, and we are also seeing a reliance on agency staffing, but I'm not sure whether Arlene wants to add anything to that.
Yeah, do you want me to respond to that now, Jerry, or when my paper later then? So the 2 parts of the learning disability spend. One is the health spend, which is shown as an overspend within the mental health budget, which relates to New Craigs and the assessment and treatment units. The 6-bedded assessment and treatment unit currently have 2 individuals and 1 last year who has now gone out of area, but 2 individuals who are requiring 2-to-1 levels of support. That's over our workforce establishment, and so therefore that is a pressure on the budget. And many of those staff where last year coming from agency, we've done a huge amount of work. You can see that from the supplementary staffing about reducing our agency spend within New Craigs. And so now those staff tend to be more from bank. So you'll see a decrease in that figure from the reduction from agency to bank staff, but not a decrease in the number of actual staff that are required. So there's still going to be a pressure at the end of the year around that, but based on the clinical need. The adult social care and also within the health cost is one individual who is currently in an out of area placement receiving specialist care, and unusually that figure, which usually the budget for out of area placements usually sits within a CAG budget, has been transferred into the mental health learning disability budget. So you're seeing it there. And there's a piece of work being done around about an alternative solution for that individual. The adult social care overspend also is overspent and continues to be overspent, and that's around about the demand for individuals requiring support in a community setting and people within their own homes. And again, there's some work, and I'll talk about that in a bit more detail when I come to the paper about what we're doing around about the support sector and some new models of care, which we hope will have an impact on that.
Thank you, Arlene. That was very helpful. And does that pick up your point?
Yeah, that's very helpful, Arlene. Thank you. In relation to the demand for individuals in a community setting, so is that mostly in the independent sector then that we're...
Absolutely, the learning disability spend, and kind of I don't know if I've broken it down completely, but we have very little in-house support provision within NHS Highland for adults with learning disabilities. There's only two projects, one which is one house in Inverness, and then some support in Portree. That's all. The rest of it is all commissioned support. And what we're seeing is an increase in individuals with more complex needs. We're seeing young people coming through with very complex autism, whose families can no longer care for them, and so they're moving into independent tenancies with high levels of support.
Okay. Thanks, Jerry. Thanks.
Thank you, Arlene. Thank you. I think what we probably have just will allow Elaine to move on to 24-25. We're probably just there in microcosm. We have lots of the issues in 23-24 are just going to continue with us into 24-25. It might be a new financial year, but I think many of the issues, which I'm sure Elaine is about to tell us about, are going to be very, very familiar to us. Elaine, we'll maybe just move on to 24-25, and if you could give us an overview of where the board financial plan is sitting at the moment, and what we've submitted to Scottish Government and what we've had approved at the board. Thank you.
Okay, so we submitted a plan to Scottish Government in March this year, and within that plan we identified an initial gap of 112.5 million. We know that our brokerage cap is 28.4 million, which meant that we had to deliver over £84 million worth of cost reductions in year to reach that brokerage cap. The plan wasn't approved by Scottish Government, but it wasn't rejected either. It was something that we were aware that there was further work required on, because we had split the 84 million into value and efficiency schemes, so that's a 3% savings on a recurring basis. We'd looked at some pieces of what we've termed choices, where it's not something that we would immediately want to do, but in order to deliver the financial position, we would have to go down that route. And we also had the adult social care position sitting separately within that. So at that point in time, we'd identified a gap of 23.3 million. So further work was undertaken. Scottish Government have been supporting us around what their expectation is. So there was a paper submitted to, or a paper presented to the board at the end of May, with a recommendation that, I'm just actually having a look at the actual wording of the recommendation. Apologies. The recommendation for the board was that the proposed budget was agreed with a 22.2 million gap from the brokerage cap of 28.4 million. And when I take you through the month 2 position, I can show that just on the screen. And the board were also asked to acknowledge the challenge of delivering a 3% recurring savings plan and delivering a balanced adult social care position. So we've revisited the opening gap that we had. It's come down by just £500,000 because of something that's been funded centrally by Scottish Government and won't actually be hitting the board position. We have then looked at the value and efficiency schemes. So we've identified 21.7 million of opportunity there that we're working to develop PIDs on and actually get the schemes into delivery. We've looked at the Argyll and Bute position, so they've got both value and efficiency, but they've had choices a piece as well. So the commitment there is that we'll deliver a break-even position within Argyll and Bute. We've split the adult social care position into a value and efficiency element and a choices element. So the value and efficiency element's the 3% recurring, so it's 5.71 million. And we're also expecting some financial flexibility around allocation slippage that we see on a year-on-year basis. So that's 7.5 million. So that took us to a gap after that improvement activity of 50.6 million. And as I mentioned, that's 22.2 million adrift from the brokerage cap of 28.4 million. So we will be reporting against the position that was presented to and agreed by the board, but we're also doing that alongside the reporting into the Scottish Government around where we are with getting to a 28.4 million brokerage cap. So we might bring, we've not decided just exactly how we're going to present that as we go forward, because we are reporting almost in two different elements, but we will progress that as we go through the year. So happy to take any questions on that one as well.
Thank you, Elaine. I think that's really helpful. Maybe if I could attempt to sum it up, and I know this will become clearer when we look at the month 2 report. So we've got a brokerage cap of 28. Is it 28 million? And that still leaves us about 20, and we're 22 away from that at the moment. But even to get to that, say, circa £50 million position, we have to deliver as a board a 3% recurring savings target, and that assumes that the adult social care position will deliver a break-even position as well, whether that's through a combination, more than likely through a combination of savings or readjusting the quantum. So those are the challenges which we actually face here. And in addition to that, just to bring into conversation we've just had with Arlene, that assumes delivery against operational budgets. So there's quite a challenge in there. That's the context for us as we move into the transformation discussions. And I think it's useful just to think about those individual elements in terms of the challenge that faces the board and then is going to face the partnership as we move forward. Anne.
So I think that that sort of summary from yourself, Jerry, is really helpful context. And for those of us who struggle more with the figures than you do, with your experience, I just wondered if I could clarify something there. Is it the case then that as far as adult social care is concerned, we're in a situation where at the year end, it's potentially, I think the forecast at the moment is just shy of 24 million, plus the opening gap of 23 million if we don't manage to get support for that gap? Is that the potential total situation at the end of the year, or is it one or other of those? Sorry, I'm not quite clear yet what we potentially might be facing.
I think I know what the answer is, but I'm going to let Elaine speak because it's
So I'll speak in it in a bit more detail when I put the slides up for month 2. But at the moment, we're forecasting an overspend within adult social care at the 31st of March 2025 of 16.2 million. That assumes at the moment that we will deliver the 5.71 of value and efficiency schemes within adult social care. But whilst we're forecasting that's an overspend within adult social care, what we are doing centrally, so for the board as a whole, is assuming that there will be support to balance that adult social care position, because the messaging coming from Scottish Government is quite clear that it's not acceptable for us to have an overspend within adult social care impacting on the health position overall. So we're doing quite a bit of work at the moment around that.
Does that answer your question, Anne? Yeah.
Sorry, it was my mistake. It's not the 24 million is of course the total partnership predicted overspend, not adult social care. So sorry about that. I've got the wrong figure there.
Okay, so I think that's useful context just to set the stage for the next discussion in terms of firstly, Rhiannon's going to take us through the board's approach to transformation plans, and you'll see a little flavour in there of specifics in relation to the partnership, and then Pam is going to take us through some very specific work which she is leading on behalf of the partnership to deliver against our challenges, and then we can just have a general discussion as we move through that or at the end of that, just so we're absolutely clear on what's going on. So I'll maybe just hand over to Rhiannon now, who'll take us through ostensibly the paper that was presented included in your papers at 3.1, but apologies for jumping about a little bit. Thank you.
No problem. Thank you. I'll just share my screen. So what I was asked here for today was an overview of the pieces of the transformation work in its totality that the Health and Social Care Partnership is undertaking. It is an overview. You've had the slides. There is a lot of information in the slides. Don't intend to go into all of that, but it's there and will perhaps help with discussion in terms of what you want to know next, really, I think. I don't pretend to be an expert on the detail in any of these because they have been developed by the professional teams. Okay. So all of our transformation work has been developed under the guidance, under the overarching strategy, being the Joint Strategic Plan, which this committee has seen in depth and signed off. It came into play from in 2024, the beginning of this year, and takes us through to 2027. The focus in the strategic plan is around enabling independent living as close to home as possible, ensuring that services are efficient, effective, equal, affordable and sustainable. In terms of how that's translated and is then taken out to communities to be developed in engagement in terms of a local plan, we developed a strategic charter which is called Home is Best, and you'll see as I go through the presentation that there's quite a lot of detail in there that again you may want to draw out another time. In terms of implementing the Joint Strategic Plan and ensuring that we are doing so through engagement with our localities, I thought I'd just give a very brief update on where we are with that process, because that is where our transformation is going to be happening. We have now developed our district planning groups, and they have all had their first meetings and have given their first report into the strategic planning group. Their first meetings have consisted very largely of sharing strategy, so the Joint Strategic Plan and the strategic charters, and also some of the transformation work that's already undergone, so that we can start with those groups really understanding where we're at the moment. We're not starting from nothing. And then the third large section of the meetings has been devoted to what's important to you. So for the members of those groups, they can start to bring in their issues where they're finding there are gaps and perhaps areas where we want to see some more development. Hand in hand with that, we've also done some development with the strategic planning group. We're revising their terms of reference, where we're getting to understand how they link with the district planning groups, with this group and with the joint monitoring committee as well. So where do they sit in terms of influencing the strategy as it goes forward? So this is our Home is Best strategic charter. On the left-hand side, we can see here that we've got our aim at the top. So enabling people to live their healthy lives and as independently as possible, where possible. We have an outline problem statement, and we have our aims and objectives to the left. So this is what we are aiming to do. And as I said, the Joint Strategic Plan is this. This is the interpretation of it. It's here really for you to be able to see how we're using that information, how we're taking the Joint Strategic Plan and putting it into something that we can say these are the bullet points, these are what we're really trying to achieve. And this is also what we have now then used to develop sub-charters. And the sub-charters have then been developed into driver diagrams. The driver diagrams have then developed into work plans. And what I'm going to show you next will be the driver diagrams, again, because it encompasses everything, the detail, a lot more detail in the work plans as well. So an example of a driver diagram, this relates to the strategic one, so the Home is Best. You can see that we've worked, we can work left to right or right to left. I think often we work as a team, as operational teams, right to left. So we have lots of ideas and then we work out how it fits with the vision. Obviously the strategy starts with the vision. So we have the vision on the left, what we're trying to achieve or need to ensure in the green. And the green points are those that develop into the work plan. So very high level, we're reshaping services at district level. We're working with partners and we're improving outcomes and experiences for staff and for patients. And then jumping over towards the right to the sort of peachy colour, this is what we're doing. These are the work plans. So the care programme driver diagram is a sub-charter. So all the next charters that are coming up are sub-charters. So we're interpreting the top strategic charter, the Home is Best, into what the care teams do. So this is what districts have. This is the element that the districts pick up, again, to work towards the same vision. And they're doing the same thing. They're reshaping their services at district level, building partnerships and improving experience. And on the far right-hand side in the peachy colour, again, you can see that there is an overlap here with the unscheduled care charter. And this is where we see the engagement, the way we implementing our plans and our action plans through engagement with the districts in particular, and through our workforce and how we develop our workforce to be able to deliver. The primary care driver diagram is looking at the very more specific areas in primary care that will link in with those district redesigns. So they're looking to create a more sustainable operating model for primary care services, rebalancing primary and secondary care services to meet the needs of the people, providing continuity of care for the person as close to home as possible. So again, linking in with the Home is Best theory, and delivering whole system integrated models of care. So linking in with the district plans, and a lot of detail there in the peachy colour on the right as to the actual actions that are being taken. The same for mental health and learning disability programs. So here they're also doing everything that's gone on above in terms of working in the districts and engaging through those groups. And they've broken down a little bit further how they are going to do that as a mental health and learning disability service. And again, on the peachy side, we'll see how many of those come through in the governance structure for NHS Highland as well through the work streams. And the final one is the urgent and unscheduled care driver diagram. So this diagram has been developed by the Urgent and Unscheduled Care Programme Board. So it's a whole system diagram. And we can see here how the community services link in with the acute services in particular, along with the primary care services to enable a whole system flow. These are work streams that we've talked about a lot in this committee with obviously our impact. We're aiming there is a 0 patient wait in emergency department. particularly at 12 hours. So that's the when people go through into admission. So we're talking about people who require admission, and the work we're doing there to try and enable the flow through the hospital, through the whole system, and into community hospitals and return home as well. In terms of the NHS Highland approach to performance and efficiency, in particular this year, we have two structures which have been set up. One is the Strategic Transformation Assurance Group, which is the top line on here, the top half of the diagram. And these are for longer term redesigns. They're about scoping, they're about strategic needs analysis, and will lead into choices that that not just us as a community would require to be chosen, but also through the EDG group. So these would be organisational choices informed by the work that we're doing now. And at the bottom of that slide, we can see that the second structure is around value and efficiency. So the value and efficiency accountability group. These are around much shorter term, within year outcomes, particularly based around savings. So these are the first two slides are the work streams that we have as a partnership through the value and efficiency group. The first slide is all around reducing the use of supplementary staffing or locums, and you can see there that we have work streams in primary care, in nursing, AHPs, mental health and learning disability, and also adult social care. And the second slide shows the areas that we're looking at in terms of further system change. So for tech, so in particular there we're looking at the use of digital solutions to improve the person's experience, improve their care, and also perhaps be able to use our staff a little bit more efficiently. So in particular, we're looking there at the use of telecare services and virtual support at home. TARA is a redesign, a transformation of the administration support, business support services throughout the community and throughout the partnership, and links in with the acute work stream, which is looking at the same for their area, and also in the corporate work stream. So we're all working together on those. We're looking in particular there to improve the professionalism of the service, the way the service is viewed, and staff experience there to enable flexibility and careers for people who start off in administrative roles. Morse is about the electronic record, so ensuring that we're using as much as we can our electronic records system and rolling that out further. Both for quality and efficiency purposes. Integrated service planning, we're looking at that in both mental health, primary care, and in the community for AHPs and nursing. And that's a data-led planning which includes finance and workforce and performance, so a triangulation of those three pieces of data or data-led planning, which enables us to create services which are both provide a quality and equality of access across their patches, across their services, but which are also able to sustain. Vaccinations, we're looking at the service model there and ensuring that that's a sustainable model going forward. And the police custody, forensic medical service and sexual assault service, again, is a workforce redesign, again, aimed at sustainability in the workforce. And then the final slide is the longer term pieces of work. So as I say, these are about choices going forward. They're about largely gathering information at this point and creating strategic assessments. We're looking at potential for consolidation options around buildings in our districts, looking at our estates, how we use them. We're redesigning our out of hours and how they link in particular with the Flow Navigation Centre, ensuring that we have appropriate and effective alternatives to being taken to an acute hospital. Geographical approach to home is best implementation, so that's through our district planning groups. So we're reporting through STAG on how we're doing those. An end-of-life services project is around the future shape of our end-of-life services and how we work with our partners. Hospital at Home is looking at how we create a sustainable hospital home service in each district, working from our pilot sites and an evaluation of those pilot sites. The mental health and learning disability model of care is looking at redesigning the model of care there, linked in with a strategy, which links in with the joint strategic plan. And the final one is around proportionate care. So this is about the use of assessment, skills and equipment to enable a reduction in the amount of care that requires, or the number of people that require two-handed care. So we would hope as well that that improves people's experiences as well of care. And that is, as I say, it's a quick run through, it's an overview, and it's really designed to create discussion. Thank you.
Okay, thank you, Rhiannon. I think that as you say, there's lots in there, and there's also lots in the paper. I'm going to bring Muriel in, but I'm really going to restrict the discussion at the moment because I think we need to hear from Pam to actually see how this is actually translating into operational issues. But Muriel.
I'll wait till I hear from Pam. The one thing that maybe Pam will cover as well is the Morse connectivity and compatibility, because we hear at local levels that it doesn't work and it creates a lot of angst for the staff on the ground. But I'll wait till I hear Pam because I've got a few questions, as you would expect.
Okay, Pam, we'll hand straight over to you, Pam, and you can perhaps take us through how this is actually translating and how you're now actually taking this forward with your team. Thank you.
Okay, so the district planning groups, as Rhiannon has outlined, is key to delivery. So, working with our population and our partners clearly across the strategic planning partnership, making sure that we are all engaged in that community with the population, using the data that we've got to discuss what services we're currently delivering and how people want to receive services in their area. We've also been doing a lot of discovery work, as Rhiannon mentioned, really to have that look across Highland, where we're spending our money, where we've got our hosted services, and how all of that is set out and what that looks like. Key providers around the work that we're doing is primary care. So we also have a specific primary care charter, and we've also got an urgent care work stream. So primary care is very, very important to us in terms of delivery, in terms of augmenting and leading our multidisciplinary teams out in the community, getting consistency across our community hospital models. Is really important going forward, so that we can work across the whole system and we make sure that we've got whole system flow, specifically around how we manage our delayed discharges, both within our acute sector and across mental health and learning disabilities. There's a number of value and efficiency work streams in terms of workforce that should allow us to be more efficient. However, we do have significant workforce challenges across Highland that we're all absolutely aware of. Technology absolutely gives us a good opportunity to streamline our services, to uptake the technology that's needed to support workforce. We also have other additional pieces of work and working with other partners that should help us to be more efficient in the use of technology, to manage staff time better, and to release time to care back into our operational service. We do have a number of strategic choices that we want to take forward, and we've been mapping and looking at those models, looking at consolidation across Highland, but engaging very much with the communities. And a key piece of work that underpins that is the quality impact assessments and strategic needs analysis, or strategic needs assessment then. So understanding the population need is an absolute key piece of work that we're working on. In terms of implementing the strategic plan, we do have underpinning pieces of work, and in terms of our partnership work, in terms of housing, then not only for workforce but supported housing models, working very much in partnership with the Highland Council on delivery of that. And the Highland Council also have a £20 million worth of transformation funding to support us in the partnership to look at transformation and redesign. So one of the early pieces of work we've done then, Muriel, is to align some technology-enabled care or some technology support in terms of workforce to help us deliver not only the technology-enabled care needed for people at pace and in their homes and technology-enabled homes, but also to help us embrace new technology and make sure that IT systems, etc., are much improved. We've got to re-provide the Care First model within adult care. So that will be a key piece of work, and within the community we're hoping to roll out more. Unfortunately, both of those systems don't talk to each other. However, that doesn't mean that we can't still work in an integrated way within multidisciplinary teams using the wider IT formats and platforms that we've got to enable efficient ways of working and good communication between our multidisciplinary teams. We also have other value and efficiency work streams around pharmacy, for example, so making sure that we reduce costs in pharmacy. Jill may talk to you later about the work that we're doing within primary care around 2C practices, because they're the ones that are board running within our gift, to actually do dynamic development work with. But ultimately, we would want to have a plan to return them to general practice going forward. We have a vaccine improvement group that we've just set up that's got 29 work streams now across a number of 7 thematic domain areas, and each of them have key work stream leads, and we've set that out in very much a project management approach, so making sure that we've got the overall plan and that we've got mechanisms that provide the assurance that we're reporting, that we're making improvements, that we're able to monitor variance, and that we are improving our data system. So we've had quite a lot of support to review the data systems that we're using within the partnership, and that is beginning to bring us a bit of value. Also, we have been redesigning our urgent and unscheduled care work streams, particularly that community urgent care, the community urgent care approach, and that goes back to how we engage with our communities again around how they access services and how we move people through services very quickly. Ultimately, our goal is home is best, and in terms of people who are in hospital, the question, why not home today, and working at pace around a number of models that we've been developing to test out, new ways of working within urgent and unscheduled care. Key to that will be the Royal Northern Infirmary, where we've developed a new interim care model, so we're beginning to see some good flow through from Raigmore Hospital, for example, and wrapping around enhanced care through the community teams has enabled us to discharge people. I would say that just recently we've been impacted a bit by some increase in COVID, but we're still managing to move people through the system. And we're also looking at new community support models that we're trialling across the districts, and working very much in that space with our communities. Key around that is how we work within our strategic planning group, how we work with our partners, how we engage with our partners to change the models. And I'll talk a bit more about that when I do my presentation, Jerry, which we'll just come on to.
Muriel, do you want to bring your questions in at the moment, or should we just move straight into Pam's slides?
Just move into Pam's slides.
Thank you, Muriel.
Answers maybe in there. Thanks.
Okay, I shall just do the sharing of the screen. Okay, that should be the slides coming up now. Can everybody see them? And I'm just hoping that they will just jump on to slideshow. Yeah, can everybody see the slideshow? Yeah, nodding heads. Okay. So we've been developing an adult adult social care cost reduction plan. And first of all, I wanted to display just how we're spending some of our funding that we have in NHS Highland. So the first slide looks at care home and care at home slides. So the slide in the top left-hand corner then is our weekly unit cost, how much we spend within our care homes. And you can see that the board-run care homes that are detailed across the bottom, you can see that we have a higher unit cost based on our current occupancy. And we can see for the independent care sector, you'll see the ISD lines described along the bottom bar of the chart.
I don't think the slides have moved on. We're still sitting looking at the title slide.
Oh goodness, has that moved on? Has that one moved on?
No, we're still sitting. It looks as if it's in presentation. Not.
Sorry about this. Let me just finish what I'm doing. Let me end the show and start again. Sorry. Right, what slide can people see? Any?
That's unit costs. Yep.
Yeah.
You can see that one now. I'll try and put it on slideshow again and see what happens. Okay. So as I was explaining, we can see the difference between our statutory service provision in terms of the homes that are named across the bottom bar, and the line around the independent care sector nursing rate and residential rate. You can see that we're spending significantly more in terms of our care home. And if we look at the care at home costs then in the bottom right hand corner, then we can see that we have significant, in the blue column there, we've got significant costs in terms of NHS Highland in-house run care at home services, but also variation across how much we spend, or how much it costs to deliver care at home services in a urban area, in our rural areas, and where it's more remote. So the more remote and rural we go across Highland, the more expensive the care is, in terms of what we're funded for, and our in-house provision is absolutely extremely expensive. Right, let's see if this moves on. Has that moved on? No. Okay. Has that moved on? Oh.
I think you'll have to click on the slides in the left-hand side, to make it change.
Make it change. Okay. And I can't quite see them. I'll just have to try and do it from this screen.
Okay.
Hopefully people can look at the information pack and see what they've got. So then if we look at the slide that's on the screen, then this is about our NHS care home provision in terms of supplementary staffing. So you can see that we're using a significant amount, particularly if we look at the far right hand side of the graph, significant costs within home farm, almost substantively agency costs, very high agency costs in Main's house, and moving along, we were spending significant costs within Strathburn. So particularly as we go across remote and rural areas, we are having to spend a lot of costs in terms of what we're spending. So what we want to do is change that model and commission more into the independent sector to be more cost effective. Has that one come up? Can people see that one?
Yep.
So thank you. Thanks, Anne. So Elaine mentioned earlier about our value and efficiency targets, and also Rhiannon spoke to these. So the specific programmes that we have within adult social care then to meet the 3% target, which should be 5.71 million. We have so far identified 3.684 million of savings across the areas shown on this slide. We've started to translate some of that figure from technology-enabled care. We've started to transform some of that into an actual cost, so we're hoping to increase that figure slightly. So we're looking at reducing some of our management planning and planning costs. So that's workforce senior post reductions. Also looking at younger adults and complexity. So we already had a discussion on the spend that we have in that area earlier on, but we do have an opportunity to create some new models of support provision to develop community assets and also to enable collaboration through our commissioning approach. Building-based daycare services, we're changing the model around daycare, so that should release efficiencies across 4 daycare services, and we've already begun some of that work. And that also includes some workforce savings as well, when we look at how we manage staffing and how we manage staffing across both elements. In terms of income maximisation, we are looking for increased service user contribution to care home costs. So that's an active programme that's in place at the moment, and a review of option 1 and 2 efficiencies in line with independent care support. We're redesigning our in-house services, as I've already showed on the slide. So the big blue slide, the big blue figure on the big blue column on the previous slide needs to come down. So we're going to use a commissioning approach to change our model. And we also want to look at how we're utilising some of our underspend, so rebalancing our budget, looking at resetting our budgets, and looking across our integrated teams and business supports. So those types of value and efficiency work streams should get us to the 3.684 million, and we'll add on additional savings around technology enabled care. So some of the action that we want to take and support a change in the model is holding all vacancies. Now, we're not going to stop appointing to posts. What we want to do is engage with the external sectors so that they've got a chance to recruit to workforce to be the primary providers of care at home. So that work will be done in partnership. We're not going to stop recruiting in NHS Highland, but we must work in partnership with the sector to change the model of recruitment, because we're all competing for the same staff. So we still have to have a cost against that. We need to redirect all Inverness urban care at home activity to the external sector. So again, the commissioning approach, and again, the reprovisioning of identified in-house care homes and see if we can attract new providers into Highland to provide care within our care home settings. Arlene may talk more about younger adults and complexity, so we're doing a lot of work in terms of the efficiencies that we can achieve with independent sector support, and our commissioning approach is going to be key to that. And also in terms of corporate targets, we're in the middle of identifying a 3% target for that needs to be articulated. Some of the work that's out of scope to the cost of 56.6 million, these are things that we can't actually stop doing because they're essential to delivery, and we need to work in partnership with the Highland Council. So these are the options that we've agreed are out of scope for savings. So that would be like non-residential care, in-house daycare, meals, lunch clubs, etc. We currently fund those from the quantum. Younger adult care homes, the specialist care home provision that's very specialist and that we provide in-house. Younger adult centres, we're looking to reduce commission spend and activity, so we need the remaining internal position to stay in place. Option 1 direct payments, third sector finance, how we're funding the third sector, integrated care teams and business support, all of that support needed to deliver. The telecares and carer support, we're needed to increase investment in that area, so that's an area where we won't be looking for savings. And the support services that support care at home sustainability, a large element there that we won't be looking at. But moving forward, we need to have a twin track commissioning approach. So clearly we need to reduce what we are spending and providing in-house, and we need to work more with the wider sectors to make sure that we commission more robustly and we commission services that they have to, that they can respond to and deliver. In terms of the cost containment map then, on the left-hand side, the yellow sections there are the strategies that will help us reduce demand, so technology, promoting self-directed support, the interim care model I mentioned earlier, and making sure that we at pace deliver on discharge without delay and get people home. The orange section on the right-hand side is where which we want to reduce costs and maximise our income across all of those areas, and our efficiency and outputs in terms of the leadership I already discussed, and our care at home and complex needs redesign. So in terms of commissioning, we need to work more on our market facilitation plan. We're taking this forward with our strategic planning group. So that's based on a shared understanding of need and demand. So in terms of the slides I'm showing you today, there's a much bigger slide deck with quite a detailed drive into how we're spending our money, where we're spending it, the services that we're getting in turn from that. So the market facilitation plan really underpins the commissioning plan because it's the vehicle for delivery going forward. In terms of the areas that or the questions that we need to ask, that's what the market facilitation plan will address, is around what's the demand, what are the requirements, what do we need, where do we need it, how are we going to obtain it and secure it, what do we do to understand the market, the current market. So working with our partners is absolutely key in this area. This is not just something that we have to think about ourselves and wonder, what's out there. We really need to engage with the market about what's possible. In terms of our market facilitation plan, so far we've got our high-level commissioning intentions, some of that spelled out in the presentation. We've got high-level commissioning priorities around care at home especially, and we've got very good sector relations and market understanding. So our strategic planning group is maturing. Our district planning groups where we engage more locally, are in place and are maturing. We've not got a sort of joint strategic needs analysis, so our joint strategic planning is not informed by joint strategic needs analysis, but we do have the district profiles that were appended to the strategic plan for each district area. So we've got data, we know about our local populations, and that provides the baseline and the start of the discussions as I outlined earlier. We've got no specifics of what's needed where and in what quantities, but that's what we're working on, trying to develop. And in terms of the wider engagement, we really need to be sure and be clear about how we're engaging with our communities, how we're engaging with our staff teams, and how we're pulling all of that together. We've got high-level commissioning intentions across care homes and care at home. So I've already outlined what some of those aspects will be from the presentation. And we also have quite a detailed map around our care homes in terms of currently where we're providing them and where our strategic important areas are. And you can see that remote and rurally, and we know from our experience, there has been a significant loss of small, remote and rural care home provision, either services in suspension or it looks like the key strategic care homes that we have that are independent are mostly in our urban areas. So the links to the quality improvement work, just looping that back then, we have some developments to do around the CM 2000 scheduling tool, so that really supports care at home. The Care First replacement I've already spoken about, and Rhiannon has outlined the value and efficiency and STAG work streams across supplementary staffing. The TARA business and admin one, we still have to provide that figure specifically for adult social care, because there are some staff within that would fit within that value and efficiency work stream. So we still need to add in a figure for that. And of course, that our whole system redesign work that Rhiannon has outlined on this slide, promoting the home as best redesigns, particularly in Inverness and Caithness at the moment. So I will stop there. Sorry about the slides not working properly, but hopefully everybody has had a chance to see them either in the papers or on their own screen. Thank you.
Thank you very much to Pam and Rhiannon there, and I'm sure we will all recognise the vast amount of information we've been presented with, so I don't expect us to be able to go through it all and review it all today, but I think we'll have another opportunity when we have a development session in a couple of weeks, actually, to take some of the key points there, and that will build in that's what we were trying to get at when we were talking about strategy, and how do we translate strategy into operational deliveries, and indeed how does operational delivery and operational constraints impact on our aspirations to deliver the strategy. But before we move on to 24-25, I'll maybe just throw it open for a few questions, and we'll see if Muriel's questions have been answered. I suspect Muriel will have some which she just wants to come back to, but Kay, I'll start with your good self.
Right, sorry, I've got a list.
Well, I'm conscious of time, so restrict
Right.
yourself to maybe your most important ones.
I was slightly late because I'm supporting staff from Strathburn, so I was on the phone to somebody there. And so one thing I want to raise about supplementary staffing is that it has as much to do with staff retention as staff recruitment. And that seems to be an issue in a lot of places. And I think, there's more work to be done in that area, and I think especially on home farm as well, I think maybe a case in point where it's staff retention rather than staff recruitment. So, that's a big thing.
Yeah.
The reducing in 2-to-1 moving and handling to 1-to-1 moving and handling rings alarm bells for me, because obviously I do get calls from staff who've been hurt doing moving and handling with 2 people.
So the risk assessment for doing moving and handling with just one person sounds, you know, because especially if it's in somebody's home, their home is not always built as we would like, you know, furniture in the way, carpeting, one thing and another, and staff do regularly get hurt, sore backs, you know, or other issues through moving and handling. So that was an issue. The building-based daycare does it sometimes keeps people out of residential. You know, it offers that support, and you know, to people who maybe can't stay in their own home during the day or live with families or one thing and another. It offers that support to people and offers that support to families. So getting rid of building-based daycare for adults with learning disabilities or older people or whatever could cause more of a knock-on effect as far as people moving into residential, and therefore people moving into residential costs an awful lot more money than providing day care provision, which can offer that support to lots of people in one place. Telecare, we've raised this issue before, that sometimes it doesn't work in rural areas because I think then, and because you need the two people usually to be on, you need people to be on call sometimes for some of the systems that are in place at the moment, and it's sometimes a problem finding those people to be on call because most people are out during the day and things. I think that's about my list. Is that quick enough for you?
Thank you very much indeed, Kate. No, you make some really valid points there, and I think rather than asking Pam to go through them all individually, I think the points you raised just echo the need for any service change or any service redesign to actually take really into account all the practical issues and actually the full range. It's very easy to say we can save £1 over here. Doesn't really help if we start spending £2 over here or we adversely impact other things. So,
yes,
so
and the residential care, as far as care homes is concerned, is saving beds, and beds in hospitals are more expensive than residential care. So it's, you know, it's looking at the whole of the thing rather than just looking at, oh, we can save £5 over here, but it's going to cost 20 quid over here, you know.
Correct. I'll bring in Muriel and then Anne, and then I'll maybe let Pam just address the wider approach as well as any specific issues which Muriel and Anne raised for us. Thank you, Muriel.
Thanks, Jerry. Yeah, I think everybody's head will be hurting a wee bit. There was the data in all these slides is quite overwhelming. And concerning in some, because we seem to have been in a cycle of about 10 years in Highland, talking about transformation, change, reshaping, and you know, you just, I'm concerned when one item today said there were 29 work streams, and you're going, what? You know, that is difficult for staff, but then we've got users and then we've got our third sector as well to consider in that. However, one of my things was, I'm sure it happens, or I hope it happens, but do we ever talk about the successes and the work in for a single point of contact in Highland? You know, where is that sitting? Some organisations, and it doesn't matter whether it's IJB or lead agency, the single point of contact is being hailed as a bit of a game changer in some of the new ways that they're doing it. The community support models in the district planning groups, I have concerns there. I think we need to see what's happening, and I think you've alluded to that we have a development session coming up. And we talk a lot about telecare, but telecare is not the old, sorry if I'm offending anybody here, I've got Simon at my bottom right hand corner here. It's not the fact of pressing a button and somebody answers the phone. We've got some really good examples in Highland just now where I think Arlene probably knows an awful lot more about this than I do, where we've got pilots working with some of our people with addiction problems, and keeping the results so far are keeping them out of ITU with self-harm episodes. So I think we've got to look at the wider scope of where what technology is available and the cost, and where that sits in. I'll stop because we're running out of time, but I think there's an awful lot in there, and I'm just concerned how will we know what's working instead of just talking about the cycle of change. We need to talk about the cycle of delivery as well.
Yeah, I think it's a really good point, isn't it, Muriel? That the volume can just overwhelm you, and we actually need to and that's part of it. Is how do we focus, and that's what I'm hoping we can get into in the development session as well. Is how do we actually start to talk about delivery as well as that. Anne.
Okay, so I'm also conscious of time, Jerry, so I'm just going to raise a couple of points that I think it would be useful to hear more about in the development session. I'm not expecting a response today. Apart from, as Muriel says, there's an awful lot to take in overall. I think what today's meeting and all these presentations have done is very usefully set out an overview of the scale of the challenge that's facing us in the year ahead. So that's the first thing. I think that's, it may be daunting, but I think the way these papers have been presented together, and we're going to come on to round it off with the month 2 position, is useful in terms of setting that context for the development session. I think it would be useful in the development session to hear a little bit more about the governance of all of this, about the relationships between the district groups, the strategic group, this committee and the JMC. What we, there are issues in here about equity, there are issues in here about ensuring that we don't get into a situation where the district groups are steaming away on a front that perhaps there's not support for at a Highland-wide level. So I think some more explanation of the governance structure and the delivery structure and just how it all ties together would be useful. And I think the other, this is there's a whole host of things that one could fix on. Just one thing, a lot of the value and efficiency work streams are rightly focused on supplementary staffing. I do, in the context of understanding just how challenging it is to impact on that. We do know that we weren't very successful on that front in the previous year. So I'd be interested to hear more about the kind of initiative that Arlene mentioned in terms of shifting agency to bank, because I think in a lot of cases, we are still going to need to use staffing outside our establishments, because if we didn't, that would be in the impossible to do box without having severe and unacceptable impacts on service delivery. So I'd be interested to hear where else might we use an approach like that in terms of switching agency to bank. What are the other things that we're trying to do from an efficiency point of view that might help us reduce supplementary staffing or use it more efficiently? So I think a bit more information about the specifics of the work streams to try and manage and make our supplementary staffing more cost effective would also be helpful in the development session. Thanks. I could go on, but I won't.
Thank you very much indeed, Anne. I think those are really, really useful points. Pam, I'll maybe just give you a couple of minutes just to make some initial observations. But as you say, I think what we've actually got is a really good agenda for our development session in a couple of weeks, because I'm really keen to bring Elaine in just to, I was going to say lighten the mood, but actually just bring us up to speed exactly where we are at 1 2. So maybe just take a couple of minutes, Pam.
Thanks. No, it's really good that people are engaged in this. This is a really important discussion for the committee. Kay, in terms of the staff retention, not recruitment, I think we need to pick that up through our partnership forum and our staff governance committee, just to make sure that we are touching on that, so that we've got the read across committees. So another committee to raise that in. In terms of the moving and handling, I would give you absolute assurance that we do have quality and patient safety mechanisms within the partnership. We have got routine DTEX reporting. We've got a look in every week across all of the DTEX, and obviously that's all governed by our clinical and care governance mechanisms. In terms of building-based daycare, from the model perspective, we want to promote choice and autonomy. We want to promote carers. We want to promote working with different sectors. So moving away from day-based care is important to us, and is a strategy that we will be taking forward, engaging with our population. And in terms of telecare and our digital infrastructure, we do have a number of hubs across Highland. We've got out of hours hubs, so how we make those connections to make sure that we can respond to telecare within the systems we already have is going to be really important. There's been a lot today about the cost and the modelling. At each stage of the decisions we've taken, then there has been robust cost modelling undertaken, with contribution from a number of people, James Bain, from Simon Steer, from Elaine, people around the table. What I must say though is the underpinning challenge across all of the work that we're doing is the ageing population, more so than other council areas across Scotland, the significant workforce challenges we have. So where we've been really successful with reducing our reliance on agency staffing within the mental health sector, for example, at New Craigs, we had the benefit of employing all of the newly qualified nurses who qualified locally within University of Highlands and Islands. They all wanted to stay and work in Inverness. So that's enabled that efficiency. But what that tells us is that we've got difficulty for people, getting housing and, moving to other areas of Highlands so that they can work and grow their careers and grow their families. The infrastructure is not there, and that's something that we really need to escalate and address with the Scottish Government and COSLA going forward. And of course, the cost of care is rising all the time. In terms of our sector, our partners being able to work within the national care home contract rates is really challenging, and that's causing financial challenges for us. And of course, you'll see from the slides, the more remote and rural we go, the more expensive it is. So I think we've got a grasp on the issues. I think we've got a good plan. We've got a good framework, and definitely we will be bringing a lot into not only the development session for this committee, but also the development sessions for our joint monitoring committee, because we want to have more sight and more development. So Fiona Duncan, who's the Executive Chief Officer and Chief Social Work Officer, and I as joint Chief Officers are developing that agenda and that those subject matters to do the development sessions for the joint monitoring committee as well. I think I'll stop there, Jenny. Thank you.
Thank you very much, Pam. Kay, I'll give you the last word on this before we bring Elaine in on month 2.
Yes, I understand the daycare thing. It is choice and one thing and another, but it also relies on more staff. And if you're not giving people support in one place and you're giving all those people support in the community, there's only one group of staff that do this sort of work. You're not going to grow the workforce substantially. So if you are supporting people in the community, then you're taking in a member of staff who would have worked in a care home. You're taking a member of staff who would have, you know, worked for care at home. It's the same. It's the same workforce. So, although in an ideal world, and everybody should have choice, and everybody could have their own person at home, you know, and everything like that, it's one. You know, and there's going to be staffing issues over here because you've taken the staff to over here. Yeah, that's me.
Thank you very much, Kay. Yeah, yeah. No, you're absolutely right in your points. You just have to be careful that you're just not moving the bulge in the hose and just moving the problem over. So that was a favourite phrase of a former medical director of mine. Elaine, we'll hand it over to you and take us through month 2.
Slides should be up now. Is that okay for everybody? Good, good. So same kind of format as we've presented for the end of the 2023-2024 financial year. So the graph here, there's 4 pieces of information combined on it. The red block is where Scottish Government are expecting us to be, so that reaching that brokerage cap at the end of March of 28.4 million. The green block is the revised target, so that's what was presented to board at the end of May, so 50.6 million at the end of March. So that's the gap, the 22.3 million from brokerage cap. The blue block is the actual position, so where we are currently with a forecast here of 66.9 million, and then that dotted line, which takes us to 50.7 million at the end of March, is based on the assumption that the adult social care gap will be closed. So that's where we're working to at the moment. So we've got kind of 4 different trajectories, and we're just plotting where we are with them on a monthly basis. So forecast year-end deficit is the 50.7 million. Assume support to deliver the adult social care position. That's £22.3 million adrift from our brokerage limit. So at the end of month 2, we've got an overspend year to date of 17.4 million, and as mentioned, forecast that will increase to about 67 million. And then when we take in the assumption with adult social care, that 50.7 million. Looking at it specifically for the Health and Social Care Partnership, £4.764 million overspend reported year to date, and forecast that will increase to just under 24 million by the end of the financial year. So you'll see here that that's still showing the overspend within social care of just under 16.2 million, and that's that balance that we haven't assumed is value and efficiency, cost reductions, cost improvements being delivered. Spend on supplementary staffing at the end of month 2, 1.879 million in month and 3.7 million year to date. So still tracking at a fairly high level across both months. Adult social care, we've got the breakdown there against the individual service categories and the breakdown of this agency nursing costs within our care home. So we've split that down, so it's covering both supplementary staffing areas, so covering bank and agency. So you'll see that we've got significant agency spend within 3 care homes at the moment, but quite a high reliance in bank use within the others. So that's actually a fairly positive, because what we're trying to do when we do need supplementary staffing is to focus more on the use of bank rather than agency, because that comes in at a much reduced cost. We've built in just under 1.5 million to the forecast position, which takes into account additional payments to providers. And as I mentioned, quantum has still to be formally agreed, but at the moment we're anticipating that should improve the position by about 3 to 3.5 million. So we're hopeful that will be resolved by the time we get to month 3 reporting. Looking at North Highland communities, there's overspends year to date and forecasts in most of the geographic areas. We've got a year-to-date overspend of 1.6 million, forecasting that will increase to 17, just over 17 by the end of the year. So you'll see that little table at the bottom that most of that overspend, both year-to-date and for the forecast, is coming through the adult social care area rather than within health codes. The main pressure within adult social care continues to be the independent sector provision, particularly in Inverness and Nairn, and within Rossshire, Badenoch and Strathspey. Looking at mental health, just speaking about that table at the bottom first, where we've got the split between health and adult social care, you can see that that's actually switched from the North Highland Communities position, with most of the overspend in mental health actually coming through the health area. So an slight overspend at the moment of 766,000, with that forecast increase to 4.4 million at the end of the financial year. So what we have seen within mental health is we're forecasting a reduction in the supplementary staffing costs, particularly around agency nursing. So we'll start to see that coming through from month 3. We do have a pressure built in here for Buvidal and the clozapine drug costs. So that's a pressure of about 900,000. These are drugs that started to be used during COVID, and we did have a funding stream for them for a couple of years. And last year, the Alcohol and Drug Partnership picked up those costs, but they're coming back into the mental health position for 24-2025. There's also a forecast cost of 1.5 million built in for out-of-area costs, and we are still in negotiation with the provider to try and bring those costs down. Primary care, we've got an overspend year to date of 796,000, forecasting that will increase to 2.9 million at the end of the year. We've got a forecast overspend of, of 2.6 million within prescribing, and again that's cost and volume of drugs. We're seeing a significantly increased amount of scripts coming through in month. Just jump back, sorry. There's 880,000 built into the forecast in respect of locums and 2C practices, but the positive there is that we have recruited to some positions on a substantive basis, so we should hopefully see those costs coming down over the next few months as well. Vacancies in the primary care management and within dental are mitigating overspends in some of the other areas. When we pulled together this report, we mentioned that the SG allocations for primary care are yet to be confirmed. And within the last week, there's been a flurry of allocation letters, and Scottish Government have worked really hard to get a significant amount of allocations out to the end of Q3. So that will be reflected in the the month 3 report for Q1. The cost reduction programme, I mentioned it earlier. So this table at the bottom, we've got the gap from brokerage limit that was presented to and agreed by the board at the end of May. So 22.2 million away from the brokerage cap. So we're working to an overspend position of 50.6 million. Where we are with the forecast on that at the moment, it's actually about £750,000 better than was presented to the board. But I have to caveat with that is purely based on the cost reductions and cost improvements. It doesn't take into account pressures within the operational position. So we need to start balancing those off. And we've got the assumption still, which is high risk, that we'll have support for delivering a balanced adult social care position. And at the moment, what's coming out from Scottish Government is that anything over the 28.4 million brokerage cap should be reported as an overspend. We started looking at supplementary staffing again. So month 2 is very early. We're still trying to find our feet for reporting in the new financial year, but we have seen a slight reduction, year on year at month 2. So we've got supplementary staffing spend just under 10.3 million, so an improvement of 200,000 from the same time frame last year. So we've got 10.3 million spent in supplementary staffing set against the overspend within pay of 2.3 million. And here at the table on the bottom right, we've just got the the spend on supplementary staffing broken down across the operational areas. And then we've got the run rate. So you'll see fairly consistent within the partnership. We've seen a slight improvement within acute. Argyll and Bute has actually increased significantly in month 2 over month 1, but we are expecting them to balance the position overall. The subjective analysis, very similar to 23-24. We're still seeing pressures coming through in all of the operational areas, but that reflects the gap that we've got within the budget overall. So within drugs, 1.9 million year to date, so 1.2 almost within the acute hospital prescribing, and 746,000 within the community area. We've got the breakdown there across the different service areas within adult social care for 23-24. So as I mentioned previously, no adjustments were reported in the health and social care position that was reported at the beginning of May. Here, what we've done is we've looked at the spend across a number of the adult social care service lines from 2012, 2013, up to the end of 2023-2024. So you can see how those have all moved. I won't go into it in any great detail, but it's just there for information. And you can see just where the movements have come through. And the final slide there is just showing the breakdown of the 23-24 outturn across our in-house service provision and the independent sector. So approximately 32% of the cost coming in-house and 68% coming through external providers. So quick summary, but happy to take any questions.
Thank you very much indeed, Elaine. I think what month 2, and appreciating it is very early in the year, month 2 already showing some really worrying trends in terms of expenditure coming through there, because remember, we go back a bit, it's as well as delivering all the savings challenges, we've actually got to deliver on our operational budgets, which we're seeing coming under pressure there. I suspect we'll have none, but I'll ask anyone if they've got any questions. I suspect everyone is probably keen for a break to reset their brain before we move on in the agenda, but I'll open it up. Anne.
Okay, sorry to delay the coffee break, Jerry, but I just wondered if somebody could say a little bit about what is the process by which we will determine whether there is or there is not going to be support for the adult social care position at the year end. How is that actually going to be determined? How are we going to approach that as a partnership? Is that, I'm just not clear, is that around whether or not we're able to draw down any of the money that potentially is on offer for transformation? Is that about seeking agreement with the JMC, in fact, to some of the strategic choices that we might have to make that would reduce expenditure? How exactly are we going to get to a position where we either know or don't know? Well, whether it's either yes, there is support, yes, there's partial support, no, there's no support.
On you go, Pam. I was going to say I suspect that's probably a question which Pam needs to take away. Pam and Elaine need to take away to Helen and Fiona, but I think it's a very reasonable question which we should be expected to get the answer back to, because we can't be sitting here until the middle of April next year wondering what the answer may well be. But Pam, do you want to speak?
Yes, I was going to say that, Jerry, and also I just wanted to give an assurance that around the Transformation Fund that the Highland Council have, we have a group of both of which Simon and I are engaged with our Highland Council colleagues, and Tillette as well, and we also have a process by which we request monies and a joint engagement around how they should be spent and how we should be seeing the transformation. And just to confirm that that fund is over the next 3 years, it's not just to be used within this year. So it gives us a sense of being able to work over the 3 years on big strategic transformation change projects. Thank you.
Thank you very much, Pam. So we'll capture an action there, Stephen, for us to get informed of what the process will be for reaching agreement or not reaching agreement. It's a perfectly acceptable discussion and potential timeline for knowing the support. Obviously, it'll be the year end before we know what the level of support, if any, that's required. But I think we should be well aware of the information and the timelines. So we've reached the end of that section, which I knew before we came into today was going to be a long and challenging section. But I think it's set a good bit of context for our discussions at our development session in a couple of weeks, but also gives us a bit of context, I think, for the monitoring of our financial position moving forward. And I'll have a discussion with Pam and Elaine in terms of exactly what we need to delve into in a little bit more detail as we move forward. But hopefully all committee members and everyone in attendance has got a real understanding and can really, we now all appreciate, if we didn't before, the full scale of the financial challenge and the redesign challenge ahead of us. So my thank you to all the contributors this afternoon. I'm going to propose that we take a little 10-minute pause. Well, maybe the data-driven are not relieved. We do not have an IPQR for the Health and Social Care Partnership this afternoon. There's just a little delay in getting it produced there. So we'll come back and we'll go straight into Arlene's Learning Disability Services Assurance Report. So if we could be back, say, at 55, that would be very helpful. Thank you very much.